Welcome. NSG 419 Study Section 2. Congenital Abnormalities. Introduction. In this study section, we will discuss various forms of congenital abnormalities. We will also examine procedures for managing patients with these defects. Learning outcomes. When you have studied this section, you should be able to point out and classify congenital malformation, manage patients with congenital abnormalities. Introduction and classification. Congenital malformation is any defect in form, structure, or function which is present at birth of a baby. May be brought about by genetic causes, non-genetic causes, or a combination of these. Although congenital abnormalities may be genetic, infectious, nutritional, or environmental in origin. Most often it is difficult to identify the exact causes. Definition. Congenital abnormalities are also known as birth defects, congenital disorder, or congenital malformations. Congenital abnormalities can be defined as structural or functional abnormalities, e.g. metabolic disorders, that occurs during intrauterine life and can be identified prenatally, at birth, or later in life. Risk factors. Genetic factors. Consanguinity, when parents are related by blood, increases the prevalence of rare genetic congenital abnormalities and nearly doubles the risk for neonatal and childhood death. Intellectual disability and other abnormalities in first cousin unions. Some ethnic communities, e.g. Ashkenazi Jews or Finns, have a comparatively high prevalence of rare genetic mutations, leading to a higher risk of congenital abnormalities. Infections. Maternal infections such as syphilis and rubella are a significant cause of congenital abnormalities in low and middle income countries. Maternal nutritional status, iodine deficiency, folate insufficiency, obesity, and diabetes mellitus are linked to some congenital abnormalities. For example, folate insufficiency increases the risk of having a baby with a neural tube defect. Also, excessive vitamin A intake may affect the normal development of an embryo or fetus. Environmental factors. Maternal exposure to certain pesticides and other chemicals, as well as certain medications, alcohol, tobacco, psychoactive drugs, and radiation during pregnancy may increase the risk of having a fetus or neonate affected by congenital abnormalities. Working or living near or in waste sites, smelters, or mines may also be a risk factor, especially if the mother is exposed to other environmental risk factors or nutritional deficiencies. Classification. The defect can be categorized into 4 ways: chromosome and gene abnormalities, teratogenic causes, multifactorial causes, unknown causes. Chromosome and gene abnormalities. A condition in which there is addition, loss, or structural alteration of chromosome, e.g. Down syndrome. Each human cell carries a blueprint in form of 44 chromosomes, autosomes, and 2 sex chromosomes. Each comprises a number of genes which are portions of DNA coded for a particular protein. The fertilized zygote should have 22 autosomes and 1 sex chromosome from each parent. If there is any fault in the formation of the gametes or after fertilization, an excess or deficit of chromosomal material will result. Each abnormal pattern has a different clinical presentation. Genetic disorders. These disorders caused by a single deleterious gene or by a deviation in chromosomal number or structure. Genes are composed of DNA, and each is concerned with the transmission of one specific hereditary factor. Normal human body cells have a complement of 46 chromosomes. 22 pairs of autosomes, and 1 pair of sex chromosomes. The gene complement of the individual is known as the genotype, while the characteristic or appearance of the individual as a result of the genotype is called phenotype. All somatic body cells contain 2 sets of genes derived from each parent during the process of reproduction. A dominant gene will produce its effects even if present in only one chromosome of a pair. An autosomal dominant condition can be traced through generations. Examples of dominant condition include achromoplasia, osteogenesis imperfecta, adult polycystic kidney disease, and Huntington's chorea. Recessive gene. A recessive gene needs to be present in both the pair of chromosomes before producing its effects, e.g. cystic fibrosis or phenylketonuria. Teratogenic causes. A teratogen is an agent or influence that causes physical defects in the developing embryo and raises the incidence of congenital abnormality. Examples of teratogens are prescribed drugs, anticoagulants, preparation containing large concentration of vitamin A, like those used for treatment of acne. Drugs used in substance abuse, e.g. heroin, alcohol, nicotine. Environmental factors such as radiation and chemicals like pesticides. Infective agents, e.g. rubella, cytomegalovirus, maternal diseases like diabetes. Factors that influence the effects produced by any one of the teratogen. Gestational age of embryo or fetus at the time of exposure, length of exposure, toxicity of the teratogen, direct cause and effect may be difficult to establish. Multifactorial causes. These are due to the combination of genetic effects with one or more teratogenic influences. Gastrointestinal malformations. Anal atresia or imperforate anus. This occurs in some newborns. In anal atresia, the tissue closing the anus may be several centimeters thick or just a thin membrane of skin. A fistula often extends from the anal pouch to the perineum or the ureter in males and to the vagina, the fourchette. The incidence of anal atresia is 1 in 5,000 live births. This disorder is frequently associated with other congenital like esophageal fistula. Before surgery, neonates with anal atresia should be evaluated for other congenital abnormalities. Anal atresia is obvious on routine physical examination of the neonate because the anus is not patent. If the diagnosis is missed and the neonate is fed, signs of distal bowel obstruction soon develop. Hirschsprung disease. Hirschsprung disease is a congenital abnormality of innervation of the lower intestine, usually limited to the colon, resulting in partial or total functional obstruction. Symptoms are obstipation and distension. Diagnosis is by barium enema and rectal biopsy. Anal manometry can help in the evaluation and reveals lack of relaxation of the internal anal sphincter. Treatment is surgical. Hirschsprung disease is caused by the congenital absence of the Meissner and Elbach autonomic plexus in the intestinal wall. The estimated incidence is 1 in 5,000 live births. Marshall and Rayner, 2014. Disease is usually limited to the distal colon, 75% of cases, but can involve the entire colon or even the entire large and small bowels. The denervated area is always contiguous. Males are more commonly affected, male to female ratio 4:1, unless the entire colon is involved, in which case there is no gender difference. Peristalsis in the involved segment is absent or abnormal, resulting in continuous smooth muscle spasms and partial or complete obstruction. with accumulation of intestinal contents and massive dilation of the more proximal, normally innervated intestine. Skip lessons almost never occur. Symptoms and signs. Patients most commonly present early in life, but some do not present until childhood or even adulthood. Fail to pass meconium in the first 24 hours of life. Infants present with constipation, abnormal distension, and finally vomiting, as in other forms of distal bowel obstruction. Infants may also fail to thrive. Diagnosis: barium enema, rectal biopsy, sometimes rectal manometry. Diagnosis should be made as soon as possible. The longer the disease goes untreated, the greater the chance of developing high-sprung enterocolitis, toxic megacolon, which may be fulminant and fatal. Definite diagnosis require a full-thickness biopsy of the rectum or colon to identify the full extent of the disease and thus plan surgical treatment. Management: surgical repair. Treatment in the neonate typically involved a colostomy proximal to the aganglionic segment to decompress the colon and allow the neonate to grow before the second stage of the procedure. Later resection of the entire aganglionic portion of the colon and a pull-through procedure is done. After definite repair, the prognosis is good, although a number of infants have chronic dysmotility with constipation, obstructive problems, or both. Cleft lip and cleft palate. Cleft lip is a congenital abnormality that occurs due to the failure of fusion of the maxillary and medial nasal processes, that is, formation of the primary palate. If the cleft does not affect the palate structure of the mouth, it is referred to as cleft lip. Cleft lip is formed in the top of the lip as either a small gap or an indentation in the lip, partial or incomplete cleft, or it continues into the nose, complete cleft. Cleft lip can be unilateral or bilateral. Cleft palate is a congenital abnormality in which two plates of the skull that form the hard palate are not completely joined. It is more common in boys than girls. It ranges in severity from soft palate involvement alone to a defect including the hard palate and portions of the maxilla. Cleft palate may or may not be associated with cleft lip. May have associated dental malformations, speech problems, and frequent otitis media, the latter resulting from improper functioning of the eustachian tubes. Incidence: cleft lip as a single malformation occurs in 1.3 per 1,000 live births. Marshall and Reno, 2014. Etiology: 1. Many factors are associated with the development of cleft lip and cleft palate, and cleft lip with or without cleft palate is developmentally and genetically different from isolated cleft palate. 2. Most cases appear to be consistent with the concept of multifactorial inheritance as evidenced by an increased incidence in relative and monozygotic twins. Pathophysiology: 1. During embryonic development, the lateral and medial tissues forming the upper lip palate fuse between week 7 and 8 of gestation. The palatal tissues forming the hard and soft palate fuse between weeks 7 and 12 gestation. The embryological development of the upper lip and nose requires a sequence of complex, genetically programmed events. This involves fusion of the 5 major facial prominences occurring between the 3rd and 8th week of gestation, with lip development between the 3rd and 7th week, the palate development between the 5th and 12th week. www.bestpractice.bmj.com. Cleft lip and/or palate, the maxillary medial nasal and lateral nasal prominences converge through a complicated process of epithelial bridging, programmed cell death, and subepithelial mesenchymal penetration. Cleft lip and/or palate is likely to be secondary to a defect of epithelial fusion or mesenchymal growth. Processes involve many possible genetic loci or intracellular signaling pathways. This results in interrupted fusion of the maxillary and medial nasal prominences. In bilateral cleft lip, with or without cleft palate, the arterial network and musculature of the lateral element parallel that of the lateral segment of the unilateral deformity. The abnormal insertion of the cleft lip musculature follows the cleft margin up to the piriform aperture, and the prolabial segment receive its blood supply from the septal, columellar and premaxillary vessels. www.bestpractice.bmj.com. Midline cleft of the nose and/or lip. These are likely to arise from an interruption in the fusion of the paired median nasal prominences during embryological development. Most median facial deformities represent developmental feed defects and are sporadic with multiple. Clinical manifestations. Cleft lip and cleft palate are readily apparent at birth. Careful physical assessment should be performed to rule out other midline birth defects. Cleft lip and cleft palate appear as incomplete or complete defects and may be unilateral or bilateral. Diagnostic study findings. Obstetric ultrasound will reveal cleft lip while the infant is in utero. Nursing management. Assess for problem with feeding, breathing, parental bonding, and speech. Ensure adequate nutrition and prevent aspiration. Provide special nipples or feeding device for a child unable to suck adequately on standard nipples. Also, where there is additional problem of cleft palate, orthodontic plate may be fitted to facilitate breastfeeding. Hold the child in a semi-upright position. Direct the formula away from the cleft and towards the side and back of the mouth to prevent aspiration. Feed the infant slowly and ensure frequent belching to prevent excessive swallowing of air and spewing. Team approach is very important in the care. Psychological support, the infant and parent emotional and social adjustment. Help expedite the family acceptance of the infant by encouraging the parent to express their feelings and concerns and by conveying an attitude of acceptance towards the infant. Emphasize the infant's positive aspects and express optimism regarding surgical correction. Prepare for corrective surgery. Preoperative care. Depending on the defect and child's general condition, surgical correction of the cleft lip usually occurs between 10 and 12 weeks of age. Repair of the cleft palate is usually performed between 6 months and 18 months of age. Marshall and Reynolds 2014. Repair of the cleft palate may require several stages of surgery as the child grows. Early correction of cleft lip enables more normal sucking patterns and facilitates bonding. Early correction of cleft palate enables development of more normal speech patterns. Delay closure or large defects may require the use of orthodontic appliances. Post-operative care. Assess airway patency and vital signs. Observe for edema and respiratory distress. Position the child with cleft lip on her back in an infant seat or propped on a side to avoid injury to the operative site. Position the child with a cleft palate on the abdomen to facilitate drainage. Clean the suction line and apply an antibacterial ointment as prescribed to prevent infection and scarring. Monitor the site for signs of infection. Use elbow restraint to maintain suction line integrity. Remove them every 2 hours for skin care and range of motion exercises. Manage pain by administering analgesic as prescribed. Ensure parents are given full information about the care of the child and follow-up care at home. Congenital cardiac defects. According to London, Ladering-Ball and Mindler 2003, congenital heart disease refers to a defect in the heart or great vessels or persistence of fetal structure after birth. Congenital cardiovascular defects are present in about 1% of live births. There are many different types of congenital heart defects. They range from simple defects with no symptoms to complex defects with severe life-threatening symptoms. Congenital cardiovascular disease. A congenital cardiovascular defect occurs when the heart or blood vessels near the heart do not develop normally before birth. Congenital heart defects are problems with the heart structure that are present at birth. These defects can involve the interior walls of the heart, valves inside the heart, or the arteries and veins that carry blood to the heart or out to the body. Congenital heart defects change the normal flow of blood through the heart. Etiology. Most congenital heart defects develop during the first 8 weeks of gestation. They are usually the result of a combined or interactive effect of a genetic and environmental factors such as fetal exposure to drugs such as phenytoin, lithium, and alcohol, maternal viral infections such as rubella or Coxsackie B5, maternal metabolic disorder such as phenylketonuria, diabetes mellitus, and hypercalcemia, maternal complication of pregnancy such as increased age and antepartum bleeding, genetic factors, family recurrence pattern. Genetic disorders that may cause heart defects are categorized into 3 major groups. Clark, 2001. Chromosomal disorders including DiGeorge syndrome, trisomy 21, Down syndrome, and Turner syndrome. Single gene disorder, which might be either autosomal dominant or autosomal recessive. Polygenic disorder resulting from multiple genetic or environmental influences. Types of congenital heart defects. Congenital heart defects are generally categorized by pathophysiology and hemodynamics, the pressures generated by blood and the pathways blood take through the heart and pulmonary system. Cardiac defects or lesions are categorized into acyanotic, oxygenated blood is shunted to the body, but the infant remains pink. Cyanotic, the oxygenated blood is shunted to the body, causing the infant to be blue. They are also categorized as simple or complex. Simple congenital heart defects. These are mainly acyanotic. Septal defect, holes in the heart. The septum is the wall that separates the chambers on the left side of the heart from those on the right. It prevents mixing of blood between the two sides of the heart. Sometimes, a baby is born with a hole in the septum. When that occurs, blood can mix between the two sides of the heart. Arterial septal defect, ASD. An ASD is a hole in the part of the septum that separates the atria, the upper chambers of the heart. Arterial septal defect is an opening in the septum between the arteria that occurs as a result of improper septal formation in early fetal cardiac development. Occurs in approximately 0.19 in 1,000 live births. Incidence in Down syndrome is 20%. Normal heart and heart with atrial septal defect. Ventricular septal defect, VSD. A ventricular septal defect is an opening in the septum between the right and left ventricles that results from imperfect ventricular formation during early fetal development. VSD is the most commonly occurring form of congenital heart disease, with an incidence of 20% to 25% among neonates with cardiac defects. VSD frequently occurs in association with other congenital heart disease. The hole allows oxygen-rich blood to flow from the left ventricle into the right ventricle instead of flowing into the aorta and out to the body as it should. Narrowed valves. Simple congenital heart defect also can involve the heart valves, which control the flow of blood from the atria to the ventricles and from the ventricles into the two large arteries connected to the heart, the aorta and the pulmonary artery. Valves can have the following types of defects. Stenosis. This is when the valve doesn't open completely and the heart has to work harder to pump the blood through the valve. Atresia. This is when the valve doesn't form correctly, so there is no opening for the blood to pass through. Regurgitation. This is when the valve does not close completely, so blood leaks back through the valve. The most common valve defect is called pulmonary valve stenosis, which is a narrowing of the pulmonary valve. This nerve allows blood to flow from the right ventricle into the pulmonary arteries and out to the lungs to pick up oxygen. Complex congenital heart defect, tetralogy of Fallot. Complex congenital heart defect needs to be repaired with surgery. The most common complex heart defect is tetralogy of Fallot. It is the most common type of cyanotic heart disease, accounts for 10% to 15% of all characterized by a combination of 4 defects. 1. Pulmonary valve stenosis. 2. A large VSD. 3. A overriding aorta. The aorta sits above both the left and right ventricles over the VSD rather than just the left ventricle. 4. Right ventricular hypertrophy. The muscle of the right ventricle is thicker than usual because of having to work harder than normal. Normal heart and hearts with tetralogy of Fallot. Babies and children with tetralogy of Fallot have episodes of cyanosis, which can sometimes be severe. In the past, when this condition wasn't treated in infancy, older children would get very tired during exercise and could have fainting spells. Tetralogy of Fallot is now repaired in infancy to prevent these types of symptoms. Tetralogy of Fallot must be repaired with open heart surgery, either soon after birth or later in infancy, depending on how severely the pulmonary artery is narrowed. Children who have had this heart defect repaired need lifelong medical care from a specialist to make sure they stay as healthy as possible. Clinical manifestations. Many congenital heart defects have few or no symptoms, may not be detected during a physical exam. Severe defects have symptoms which include rapid breathing, cyanosis, fatigue, poor blood circulation. Congenital heart defects don't cause chest pain or other painful symptoms. There may be heart murmur, but not all murmurs are a sign of congenital heart defect. Some elderly children may have heart murmurs. Diagnosis. Physical examinations. Listen to child's heart and lungs with a stethoscope for heart sound and air entry. Diagnosis. Physical examination. Listen to child's heart and lungs with a stethoscope for heart sound and air entry. Looks for another signs of a heart defect such as cyanosis, shortness of breath, rapid breathing, delayed growth, or signs of heart failure. Diagnostic tests. Echocardiogram. Uses sound waves to create a moving picture of your child's heart. During an echocardiogram, reflected sound waves shows the structure of the heart. An echocardiogram is an important test for both diagnosing a heart problem and following the problem over time. Electrocardiogram (ECG). An ECG dictates and records the electrical activity of the heart. An ECG shows how fast the heart is beating and whether the heart's rhythm is steady or irregular. It can also dictate if one of the heart chambers is enlarged, which can help diagnose a heart problem. Chest X-ray. A chest X-ray shows whether the heart is enlarged or whether the lungs have extra blood or fluid, which can be a sign of heart failure. Pulse oximetry. Pulse oximetry shows how much oxygen is in the blood. A sensor is placed on the child's fingertip or toe like an adhesive bandage. The sensor is attached to a small computer unit, which displays a number that indicates how much oxygen. Cardiac catheterization. During cardiac catheterization, a thin flexible tube called a catheter is passed through a vein in the arm, groin, upper thigh or neck to reach the heart. A dye can be seen on an X-ray is injected through the catheter into a blood vessel or a chamber of the heart. Cardiac catheterization can also be used to measure the pressure inside the heart and the blood vessels, and to determine whether blood is mixing between the two sides of the heart. It's also used to repair some heart defects. Management of congenital defects, procedures using catheters to repair the defect, surgery to repair the defect, the treatment the child receives depends on the type and severity of his or her heart defect. Other factors include the child's age, size, and general health. Treatment can be simple or very complex. Some children with complex congenital heart defects may need several catheters or surgical procedures over a period of years, or may need to take medicine for years. Procedure using catheters. Catheters procedures are much easier than surgery on patients because they involve only a needle puncture in the skin where the catheter is inserted into a vein or an artery. The use of catheter procedure has grown a lot in the past 20 years. They have become the preferred way to repair many simple heart defects such as atrial septal defects and pulmonary valve stenosis. Surgery. A child may need open heart surgery if his or her heart defect cannot be fixed using a catheter procedure. Sometimes, one surgery can repair the defect completely. A child may need more than one surgery over a period of months or years to fix the problem. Open heart surgery may be done to close holes in the heart with stitches or with a patch, repair or replace heart valves, widen arteries or openings to heart valves, repair complex defects such as problems with where the blood vessels near the heart are located and how they develop. Clinical therapy. Early management of these defects is important to prevent secondary damage to the heart, lungs, and brain, including the adverse effects of hypoxemia on the child's cognitive and psychomotor development. Corrective surgery is often performed in infancy. A palliative procedure may be performed first to preserve life in children with potentially lethal heart defects and complications. With some defects, corrective surgery can be postponed with a palliative procedure, giving the infant an opportunity to grow and improve the success of the corrective surgery. Antibiotic prophylaxis for infective endocarditis is needed before and after surgical correction for many of these defects. Nursing management. Nursing management of the hospitalized child focuses on monitoring PGE therapy for newborns, treating hypercyanotic episode, supporting families to care for the child at home, and providing post-surgical care. Nursing assessment. The principle of holism and family-centered approach is used in managing the child as well as consideration of the child's developmental stage and task. The parent's participation in the decision about the care of the child is very important. Central nervous system abnormalities. These defects of the CNS are usually the result of embryologic developmental failures. They occur as a result of prenatal factors such as maternal infections or radiation, anosmia, or genetic factors. Prevention. Injection of folic acid supplements prior to conception and during early stages of pregnancy can help to prevent such abnormalities. Prenatal diagnosis through screening tests like measuring alpha fetoprotein levels and ultrasound has made some parents to choose to terminate pregnancy where there is severe neural tube defect. These measures will help to reduce number of babies with abnormalities of CNS. Anencephaly. This is the absence of the forebrain and vault of the skull. the condition is incompatible with sustained life, but occasionally the baby may be born alive. Management. The baby should be wrapped carefully before showing the mother. Seeing and holding the baby will facilitate grieving process. May be beneficial for parents to see the full extent of the abnormality. This helps them to accept reality and not to imagine something worse. Spina bifida. Spine is a slender thorn-like projections on the bones. Spina bifida is a congenital defect of non-union of one or more vertebral arches, allowing protrusion of the meninges and possibly their content. Spina bifida aperta. This results from failure of fusion of the vertebral column. Meningocele, meningomyelocele, or encephalocele may be present. Meningomyelocele involves the spinal cord. The lesion may be enclosed or the meningocele may rupture and expose the neutral tube. Meningomyelocele usually leads to neural damage, which results in paralysis distal to the defect and impaired function of urinary bladder and bowel. Meningocele is present because there is no skin covering the defect, which allows profusion of meninges. The meningeal membrane may be flat or appear as membranous sac with or without cerebrospinal fluid, but it does not contain neural tissue. It may appear at any point in the vertebral column, but the lumbosacral area is the most common site. It is known as encephalocele when at the level of the base of the skull. The sac may contain varying amounts of brain tissue. Normal progression of labor may be impeded by the large lesion. Management. Cover open lesion with a non-adherent dressing. Handle baby with utmost care in order to preserve the integrity of the sac and limit the risk of meningitis occurring. Contact a pediatric surgeon for possible surgical closure. Surgical closure carries a high rate of success. Closure may not be within 24 hours. The pediatrician should examine the baby. Findings should be discussed with the parents. They should be allowed to make informed choice about whether they want surgery for their baby or not. Spina bifida occluta. It is the most minor type of defect when the vertebra is bifid. There is usually no spinal cord involvement. Clinical manifestation. A tuft of hair or sinus at the base of the spine may be noted on first examination of baby. Diagnosis is confirmed through ultrasound investigation. It also helps to rule out any associated spinal cord involvement. Parents that had baby with a neural tube defect should be offered genetic counseling since the risk of recurrence is 1:25. Hydrocephalus. This is a condition which arises from a blockage in the circulation and absorption of cerebrospinal fluid. Hydrocephalus is a condition caused by an imbalance in the production and absorption of CSF in the ventricular system. When production exceeds absorption, CSF accumulates, usually under pressure, producing dilation of the ventricles. It is a term derived from the Greek word hydro, meaning water, and cephalus, meaning head, and this condition is sometimes known as water on the brain. Hydrocephalus results in abnormal accumulation of cerebrospinal fluid, CSF, in the ventricles or cavities of the brain. These may cause increased intracranial pressure inside the skull and progressive enlargement of the head, convulsion, and mental disability. May not cause any intellectual disability if recognized and properly treated. The large ventricle increases in size and eventually compress the surrounding brain tissue. It frequently accompanies more severe spinal bifida lesion because of a structural defect around the area of the foramen magnum known as Arnold-Chiari malformation. It may either present at birth or develop following surgical closure of a myelomeningocele. Risk factors. It is also associated with spinal bifida. Acquired hydrocephalus usually results from space-occupying lesions, hemorrhage, intracranial infections, or dormant development defects. Classification of hydrocephalus. Hydrocephalus can be caused by impaired cerebrospinal fluid (CSF) flow, reabsorption, or excessive CSF production. The most common cause of hydrocephalus is CSF flow obstruction, hindering the free passage of cerebrospinal fluid through the ventricular system and subarachnoid space, e.g., stenosis of the cerebral aqueduct or obstruction of the interventricular foramina. Foramina of Monro secondary to tumors, hemorrhages, infections, or congenital malformations. Hydrocephalus can also be caused by overproduction of cerebrospinal fluid, relative obstruction, e.g., papilloma of choroid plexus. Based on its underlying mechanism, hydrocephalus can be classified into communicating and non-communicative obstructive. Both forms can either be congenital or acquired. Communicating hydrocephalus, also known as non-obstructive hydrocephalus. It is caused by impaired cerebrospinal fluid reabsorption in the absence of any CSF flow obstruction. It has been theorized that this is due to functional impairment of the arachnoid granulations, which are located along the superior sagittal sinus and is the site of cerebrospinal fluid reabsorption back into the various system. Various neurologic conditions may result in communicating hydrocephalus, including subarachnoid or intraventricular hemorrhage, meningitis, Chiari malformation, and congenital absence of arachnoidal granulations. Normal pressure hydrocephalus (NPH) is a particular form of communicating hydrocephalus, characterized by enlarged cerebral ventricles with only intermittently elevated cerebrospinal fluid pressure. Clinical manifestation of hydrocephalus: abnormal rate of head growth, bulging fontanelle, tense anterior fontanelle, often bulging and non-pulsatile, dilated scalp vein, Meswell sign, cracked port, frontal bossing, setting sun sign, sluggish and unequal pupils, irritability and lethargy with varying LOC, abnormal infantile reflexes, possible cranial nerve damage. Manifestations in children include possible signs of increased ICP, which include headache on awakening with improvement following emesis, papilledema, strabismus, ataxia, irritability, lethargy, apathy, and confusion. The infant exhibits fretfulness, poor feeding, and frequent vomiting. As the hydrocephalus progresses, inertia sets in and the infant shows lack of interest in its surroundings. Later on, the upper eyelid become retracted and the eyes are turned downwards due to hydrocephalic pressure on the mesencephalic tegmentum and paralysis of upward gaze. Movements become weak and the arms may become tremulous. Papilledema is absent, but there may be reduction of vision. The head becomes so enlarged that the child may eventually be bedridden. Non-communicating hydrocephalus or obstructive hydrocephalus is caused by a CSF flow obstruction, either due to external compression or intraventricular mass lesions. Congenital: the cranial bones fused by the end of the third year of life. For head enlargement to occur, hydrocephalus must occur before then. The causes are usually genetic but can also be acquired and usually occur within the first few months of life, which include intraventricular matrix hemorrhage in premature infants, infections, type 2 Arnold Chiari malformation, aqueduct atresia and stenosis, and Dandy Walker malformation. Acquired: this condition is acquired as a consequence of CNS infections, meningitis, brain tumors, head trauma, intracranial hemorrhage, subarachnoid or intraparenchyma, and is usually extremely painful. Management. The risk of cerebral impairment may be minimized by the insertion of a ventriculoperitoneal shunt. This should be replaced as the baby grows. Attendant risks with ventriculoperitoneal shunt are that the line blocks and the shunt is a portal for infection leading to meningitis. Observe baby closely for signs of increased intracranial pressure, e.g., large tense anterior fontanelle, splayed skull sutures, inappropriate increase in occipital frontal circumference, sun-setting appearance of the eyes, irritability of abnormal in movements. Microcephaly. The occipital frontal circumference is more than 2 standard deviation below normal for gestational age. The head is disproportionately small. Risk factors: intrauterine infection, e.g. rubella, a feature of fetal alcohol syndrome, part of a number of defects in some trisomic disorders. Invariably, the baby will be mentally impaired. Manage a child with cleft lip using nursing process. Submit the nursing care plan of an infant with cleft lip and palate. Nursing management. Provide information about the condition and give necessary support for the family. Treatment is surgical by direct removal of an obstruction and insertion of shunt to provide primary drainage of the CSF to an extracranial compartment, usually peritoneum. Ventriculoperitoneal shunt. The major complications of shunt are infections and malfunction. Other complications include subdural hematoma caused by a too rapid reduction of CSF, peritonitis, abdominal abscess, perforation of organs, fistulas, hernias, and ileus. Provide pre-operative care. Measure head circumference, fontanelles, cranial structure, and LOC. Check also for irritability, altered feeding habits, and a high-pitched cry. Support the head and neck when holding the child. Provide skin care for the head to prevent breakdown. Feed with small frequent intake of food to decrease the risk of vomiting. Ensure parental newborn bonding. Provide post-operative nursing care. Assess for signs of increased ICP and check the following: head circumference daily, anterior fontanelle for size and fullness and behavior. Administer prescribed medications which may include antibiotics to prevent infection and analgesics for pain. Provide shunt care. Monitor for shunt infection and malfunction which may be characterized by rapid onset of vomiting, severe headache, irritability, lethargy, fever, redness along the shunt tract, and fluid around the shunt valve. Prevent infection, usually from Staphylococcus epidermis or Staphylococcus aureus. Monitor for shunt overdrainage, headache, dizziness, and nausea. Overdrainage may lead to slit ventricle syndrome, whereby the ventricle becomes accustomed to a very small or slit-like configuration, limiting the buffering ability to increased ICP variations. Provide information for discharge and home care. Arrange for the child to have frequent developmental screenings and routine medical checkups. Musculoskeletal abnormalities. These result from defects in the developmental process of various skeletal structures that may result in diverse physical disabilities. May be hereditary, e.g., claw hand, polydactyly, environmental, thalidomide, phocomelia or amalia, or multifunctional congenital hip dysplasia, polydactyly and syndactyly. Excessive number of fingers, toes, or both usually inherited, autosomal. Polydactylism is the condition of having more than the normal number of fingers or toes. Syndactylism, a condition in which 2 or more fingers or toes are joined together. Syndactyly more commonly affect the hands, may appear as an independent abnormality or part of a syndrome like Apert syndrome, in which there is premature fusion of the sutures of the valves of the skull, left palate, and complete syndactyly of both hands and feet. Separation and counting the baby's fingers and toes during the initial examination is important in order to detect syndactyly, webbing, and polydactyly, extra digits. The mother may be anxious to examine the baby where there is family history of these conditions. Treatment: the extra digit may be fully formed or is simply attached by a pedicle where there is no bone in the rudimentary digits. It can be ligated at the base and allowed to necrose. More complex attachments may require surgical removal. Syndactyly degree of webbing or fissure will determine if surgical removal will be carried out. Achondroplasia, an autosomal dominant condition where baby is generally small with a disproportionately large head and short limbs. The defect is in the ossification of the epiphyseal plates, resulting in very short limbs, large head, and lordosis which may be marked. Cognitive development is not usually impaired. No treatment is required. Give support to parents. Limbs reduction anomalies. Limbs reduction defects comprise a wide range of possibilities. Either a hand or a foot will be completely missing, while in others a normal hand or foot will be present on the end of a shortened limb. A teratogenic drug known as thalidomide is commonly associated with this condition. The child is not usually ill and may not be upset with the condition, but the parents may be worried. The child adapts and is able to cope with his or her condition. Management: prosthesis can be used in some cases. Innovative surgical techniques of transferring fingers or toes may be carried out. The parents should be given psychological support and help to adjust to child's condition. They can be introduced to a support group. Talipes, clubfoot. This is a deformity caused by a congenital or acquired contracture of the muscles or tendons of the foot. The types include Talipes equinovarus, Talipes calcaneovalgus. Talipes equinovarus (TEV) is a deformity of the foot where the ankle is bent downwards, plantar flexed, and the front part of the foot is turned inwards, adducted. Talipes calcaneovalgus (TCV) is the opposite of position, where the foot is dorsiflexed and everted. The conditions occur where the intrauterine space is limited, like in multiple pregnancy. Macrosomy foetus or oligohydramnios may likely occur in conjunction with spinal bifida deformities. These may also be family history of some deformity, more common in boys than girls. Management: mild form. Foot may easily be turned to the correct position. Passive exercise of the foot should be carried out. The midwife should encourage exercise of the baby's foot in the correct way several times a day. More severe form require manipulation, splinting, and/or surgical correction. Advice of an orthopedic surgeon should be sought. Ensure strappings for splints are not too tight and the baby's toes are well perfused. Congenital hip dysplasia. Dysplasia is abnormal development of tissue. The term applies to malformation of the hip with various degrees of deformity that are present at birth. It is commonly found where there has been history of oligohydramnios or breech presentation. It occurs more in primigravid pregnancies. The incidence is higher in girls. The left hip is more often affected than the right. Presentation or degree of congenital dysplasia include acetabular dysplasia, subluxation or dislocatable is partial dislocation of the joint. Dislocation, displacement of a bone from its natural position. Pathophysiology. Prenatal factors that are considered to influence development of hip abnormalities are maternal hormonal factors, and mechanical factors intrauterine posture. Increased maternal hormone secretion, especially estrogen, increased maternal pelvic laxity towards the end of pregnancy. The joint of newborn is also more lax, and this increases the incidence of hip dislocation, especially in females. Diagnosis. Prenatal diagnosis by ultrasound is possible, but most diagnoses are made during neonatal period. Examination of hip should be carried out by an experienced practitioner with baby lying relaxed on a firm surface. An examination by an inexperienced person will compound any pre-existing trauma to the joint. Either Ortolani's test or Barlow test can be carried out. Ortolani's test. If the femoral head can be felt to slip forward into the acetabulum or pressure from behind, it has been dislocated. Barlow's test. If on pressure from the front, the femoral head is felt to slip out over the posterior hip of the acetabulum and immediately slip back in place when pressure is released, it is said to be dislocatable or unstable. Any abnormal finding should be reported and baby referred for ultrasound and then to orthopedic surgeon. Management. After confirming diagnosis, a splint or harness such as the Pavlik's harness can be applied to keep the hips in a flexed and abducted position of 600. Splints should not be removed frequently like during birth and napkin change. Support the parents in learning how to handle and care for the baby. Pay particular attention to skin care and checking for signs of shaving or excoriation. Now we've come to the end of study section 2. Thank you.